it's such an interesting, cocktail statistic that 10% of our bone is remodeled every year. And that's primarily before the menopause transition when we're removing old bone, putting down new bone. And that's in every single bone in our body.
This is Sick Health with Kevin Ban, MD. Our show helps you navigate our confusing healthcare system so you can take control of your own health. Hi, folks. I had a really interesting conversation today with Kristy DeSapri. We talk about bone health. Specifically, we get into the physiology of bone health. We talk about some of the signs and symptoms of osteoporosis, risk factors for osteoporosis. We then get into diagnosis and treatment. I mean, this is a really good episode. I think one of my biggest takeaways is how important it is to make sure that you do this at a young age. Certainly women in their 50s and 60s are already thinking about osteoporosis. A big takeaway is that you should be thinking about bone health well before that time. The best way to support the show is to subscribe. And if you enjoy the video, please like it. Now, Kristy started in OBGYN. That's where she trained. She also had an interest in internal medicine. And then she realized that she really enjoyed women's health. And so she went to Cleveland Clinic and she did a fellowship in women's health. And now she practices in a clinic. She talks about these things every day. I hope you enjoy the conversation. Kristy, thank you so much for joining me today. I really look forward to this conversation.
So happy to be here, Kevin. This is an exciting time to talk about menopause, perimenopause, and I like that we're going to be focusing on osteoporosis prevention, treatment, and bone health, because this is a topic that sometimes is the forgotten child of what's going on in women's lives at the time of menopause.
Yeah, that's the intention. Let's focus on bone health, but also embed some of the things around menopause that people have questions about. But before we do that, I want to know about you. Why did you go into medicine?
I come from a family of teachers and finance individuals, so I was kind of the outlier when I thought about medicine and was putting Band-Aids on everyone when I was a young age, and really loved science. I loved physiology. I know you're in the same boat here. And I sort of went through the path there, thinking I was going to be an OBGYN. I loved taking care of women. I thought that anatomy was so interesting. And then started my career in OBGYN and then realized, you know what, I think, delivering babies is exciting. The operating room is exciting, but I kind of missed that long-term relationship with women and talking about women in their post-reproductive years. So actually went on to complete another residency in internal medicine, all in New York City, and then did a fellowship at the Cleveland Clinic in midlife women's health. So really coming full circle, I think, on ultimately what I thought I wanted to do when I was a young budding medical student. And really, that's where I really learned a lot about how we take care and how we can do a better job at taking care of, women's health from a sort of comprehensive standpoint, looking at bone health and menopause and breast health, gynecology, all those things kind of wrapped into one when we see patients really in those years.
Well, that's exactly why I wanted you to be on the show. And I thought we would just start with some basic physiology. Take us through bone development. What's normal? Let's start there because it'll be helpful maybe later to understand when things go off the rails.
Yep, exactly. So, we often don't think about our bones, right? When we are going to our pediatricians, when we're thinking about women in their 20s, we don't counsel on what could happen later in life. And I think this is where these discussions of prevention are so important. So what we do is we actually build our bone through our teens and our 20s. And primarily, again, my focus is women. So that's what we're going to be talking about. But males, it's very similar. And then at 20, in the mid 20s, we know from x-rays of different skeletal sites or bone sites like our wrist or our clavicle that we have all the bone that we're going to ever have. So that's called our peak bone mass. And so again, what we've really done in those early adolescent years and early 20s is important. So what happens is we have those two cells, the osteoblasts or the bone forming cells and the osteoclasts or the bone breakdown cells. And in the premenopausal years, and these are very nicely working together. They're kind of like a seesaw that's in a nice balance. We're building new bone, breaking down bone.
I think that's an important point. I sorry to interrupt you there, but I want to slow that down because I think some people think that the actual breakdown of bone might, suggest that there's a problem. But what you're saying actually is no, you're building bone, but at the same time you're removing bone, and so you're to a certain extent remodeling and sort of revitalizing bone. Do I have that right?
You absolutely do. You've been doing your studying. So you just described the bone remodeling cycle, which, we actually have two bone cycles. And again, bone is really dynamic and interesting. We do some modeling or new bone formation. That's all we're doing in our teens and 20s, putting down new bone. And that's why we tell our teenagers and our kids to get exercise, eat your calcium, vitamin D, all these things, because again, we're mineralizing and forming the bone that we're going to have. And then remodeling, it's such an interesting, cocktail statistic that, 10% of our bone is remodeled every year. And that's primarily before the menopause transition when we're, like you said, removing old bone, putting down new bone. And that's in every single bone in our body, which is, generally made of trabecular bone, which is actually the spongy bone on the inside of our cells. It's also called cancellous bone. And then our cortical bone is more what we think about when we, have a wrist fracture as a kid, or, you've broken your ankle. The cortical bone is really the bone on the outside and the stronger bone envelope. And both our bones are really important, right? So because both bones actually help us move, shape our inside and then our outside of our bones. And then we kind of hit a plateau phase, like many things in midlife. We're kind of plateauing, we're kind of maintaining our bone mass. And then at menopause, we start to lose bone mineral density. And I think menopause is this vogue term, and perimenopause, the time before menopause, is being discussed more. But really, the way we define menopause is the loss of sex hormones, primarily estradiol or estrogen, which is exquisitely sensitive to bone cells. And so those osteoclasts that I mentioned, we know that when we lose estrogen, those osteoclasts kind of go into overdrive and sort of break down more bones. And I'm simplifying this because it occurs due to, a bunch of hormonal mediators, inflammatory markers like cytokines, primarily one called rank ligand and OPG. Those are the ones that are kind of thrown off. And they're kind of going into overdrive with the less estrogen, causing the osteoclast to break down more bone. And those poor little osteoblasts, I always think about those like they're at the side of the highway, they're trying to keep up to form new bone. Those bone cells are just not as strong and really can't keep up. So the teeter-totter that was in a nice balance is now off balance. And really that is one of the major contributors to why we lose more bone and why women have a lower bone density and tend to have an inflection point of increased risk of fractures after the age of 50. We've talked about bone cells and bone mineral density, but what we're really trying to prevent when we think about bone health is prevent falls, fractures, maintain our strength, both muscle and bone.
Right. So, okay, you really laid that out nicely. So we have these osteoclasts whose job it is to sort of remove bone. To a certain extent, I'm imagining that it's getting rid of older bone, whether it be in the center of the bone, as you mentioned, or on the outer parts of the bone. And then you have the osteoblasts that are laying down new cells. And then you get this thing that gets out of whack, where the osteoclasts, the ones that break down the bone, sort of are in overdrive as you get into menopause. And then the osteoblasts aren't keeping up. Just before we get into osteoporosis, which is where things go wrong, what can we expect in terms of bone strength and bone health as women progress into their 20s, 30s, and beyond?
Mm-hmm. So this is an area that's really not discussed, right? Because this is in the purview of like the pediatricians, or like most of medicine, if there's a problem or an issue or a medical condition that might contribute to low peak bone mass. And this is where, talking about menstrual cycles is very important. Again, I see women through the lifespan, really I see some women in their 20s who are athletes and all the way up to my oldest patient's been 103. So I just love that timing. But we know that, the menstrual cycle is a vital sign for bone health. So when we talk primarily in the late teens and early 20s, you were asking me, this is one area besides things like nutrition and exercise and calcium, vitamin D, where it's really important to look at that. So, we know that women with like potentially a later menarche or first age of period might have a lower bone mass to start with, because again, they're not getting that estrogen input, or women who, the medical term of amenorrhea, meaning not having your period for a certain amount of time, like over 6 months, either due to, something like over exercise, under fueling, or just a medical condition that is, to be discovered. So that is really important during that period of time, understanding menstrual cycle, understanding the sort of the fluctuations of that on how that impacts the bone health.
Yeah, that makes me think of a friend in high school. Actually, I've known her since the first day of kindergarten, I think. And she became an exceptionally good gymnast. What also happened was apparently she wasn't menstruating. I think that was because of an intense amount of activity and exercise that she was doing. But that wasn't being paid attention to, quite honestly, back in the day when I'm referring to. And subsequently, she's had a bunch of problems as an adult, likely that stem from not paying attention. So you mentioned women who exercise to the point where they're not menstruating. You also mentioned fueling. So help me out with both of those, just because these are red flags for people to pay attention to, such that if that is happening, you want to pay attention to bone health.
Yeah. Thanks for bringing this up, because I think it's sometimes we think about osteoporosis and bone health as, a post-menopausal issue. It doesn't mean that the earlier age doesn't matter. And this can be even teens, 20s, but even women I see in their 30s and 40s with things like stress fractures, or we call those insufficiency fractures, again, from overtraining. So when I say overtraining, meaning like a lot of marathon runners, a lot of triathletes that maybe aren't, doing some cross training, or again, aren't aware of that calcium, vitamin D are as important, maybe have lost their menstrual cycle and are not sure why. Those things are all really important. And then these underfueling, these are actual conditions, right? There's something called the REDS, which is relative energy deficiency syndrome. There's something called the female triad, where again, it's amenorrhea, stress fractures, etc. So these are not conditions to be taken lightly. This is, seeing an endocrinologist, working with sports medicine physicians, working with registered dietitians, working with, just a team approach, because this does make a difference for training. And oftentimes I see those women who just come in with stress fractures, right? And it's like the end of the line here for these women, and they're wondering why this has happened, and it keeps happening. And so we have to kind of work our way all the way back and involve that whole team that I just mentioned.
And that's why I mention it, because frequently you're not thinking about bone health. It's like, hey, I've got a stress fracture, but you're not really thinking about the bigger picture, and more importantly, the underlying cause. And so a person may not, put those things together, of course, because they don't have that type of background. And so I like to call out the red flags that osteoporosis is not something that people need to worry about in later parts of life. It's something they need to think about even in the early parts of life, because it'll set you up for better bone health regardless. So, all right, causes. Let's talk about osteoporosis and its most common causes.
So I always like to just set up the definition of osteoporosis, because I think the term itself doesn't really help us unless you know Greek, right? So osteo means bone, porous means thin, right? And I, do a lot of explaining in my practice using bone models, explaining what this looks like, because I think there's a lot of fear around conditions we don't know about. I don't think all of us have neighbors, friends, family members who've had breast cancer or have cancer, and that seems to be more, palatable in our community. But what about osteoporosis? It's kind of like, well, is that an old woman's disease? Isn't that when you fall and you break your hip? But really, again, the meaning is that the bone has sort of been, deteriorating, or the bone mineral density and quality has weakened to the point where you have sustained an osteoporosis related fracture. And these fractures are actually quite common. As I mentioned, 1 in 2 women over the age of 50 will sustain an osteoporosis related fracture in their lifetime, right? So this is, on the same order as cardiovascular disease and breast cancer and all these other conditions that we think about. So naturally, when we think about thinning of the bone, we have to get there some way. And we talked a little bit about peak bone mass, and then we talked about menopause. So one of the main, risk factors for having osteoporosis is having earlier menopause. So that can be, premature ovarian insufficiency, which is a diagnosis of menopause or loss of periods under the age of 40, or, earlier menopause, women in their mid to early 40s for natural causes or autoimmune reasons. So that actually is again, an important indicator, because those women will probably live long. If we look at the statistics, women are living 1/3 to 40% of their lives in the postmenopausal years. So, if they're going to live till 80 on average, and they have menopause in their 40s, I mean, that's a lot of years without estrogen and without and affecting their bones, muscles. and then all the other things like cardiovascular risk and cognitive that go along with that. So that's really important. I think still kind of underappreciated in the medical community as well.
Kristy, let me see if I can put these pieces together. So we started with physiology. We were talking about the importance of the osteoclast, the osteoblast. Now you're talking about early menopause as a really important cause of osteoporosis. So my take here, and I want you to correct me if I'm wrong, is that you have this really fine balance between osteoclasts that are, chewing up the bone and the osteoblasts that are laying down the bone. And this is a normal process of remodeling. I think you mentioned about 10% per year. It makes me think that like every 10 years, we're almost swapping out our bone for new bone. Normal. We're normal stuff. And I took a little chance there to see if that math came together. Now what you're saying is, however, if you have early menopause, which means that actually you don't have the same amount of circulating estrogen, then you're going to be in a situation where you have the osteoblasts that aren't really being juiced, if that's the right term, by the estrogen, but the osteoclasts that are continuing to go ahead and pick up that bone, and you're thinning the bone, and you arrive at osteoporosis. So that's a really fast. First of all, is the physiology correct there? Do I have that right?
You do. You absolutely do. And again, it depends on, your bone mass that you started with too. So your peak bone mass. So you're absolutely right. And some women enter menopause with a full, bone bank. I usually use that analogy with my patients, and they've deposited all this great bone into their life before they hit menopause. And then at menopause, we're starting to see deductions. We're starting to see withdrawals in the bones.
The shout out though here is it's really important to think about bone health early. You want to put as many deposits into that bank as possible. That's really key, because there's going to become a point, and there are treatments. We're going to get there, but there's going to become a point where you're going to get out of balance. You're going to see the loss of bone, and obviously starting from a better strength perspective is going to be better. What are some other causes of osteoporosis we should know about?
Yeah. So some common causes are things like family history, right? We always ask in every medical condition, did your family have anything? So look to the left, look to the right, ask mom and dad, sisters, maternal grandmothers, paternal grandmothers. I always ask about who had osteoporosis, who might have shrunk, because that can sometimes be a sign of a vertebral fracture. Anyone who had a hip fracture, things of that nature. So family history, and actually 70% of our bone mass can be inherited. There's some statistics that share that. So again, this is where, some of those red lights you need to go on. If you have a family history of osteoporosis, you need to be thinking about this earlier. Certain ethnicities, so women who are Caucasian, Asian tend to have lower bone mineral densities. Even African American or women who are Black have higher risks of fracture, even if the bone density is higher. So we have some things to contend with, across ethnicities. Other medical conditions, so anything that actually prevents, again, as we talked about our physiology, bone from forming or increases the bone breakdown. So things like diabetes, both type 1 and 2, rheumatologic conditions like rheumatoid arthritis, autoimmune conditions, things like lupus. These are all, contribute to, low bone mass and then increased bone mineral density losses. Other conditions, so things like autoimmune, inflammatory conditions such as celiac disease, inflammatory bowel diseases like Crohn's disease, ulcerative colitis. And then there's a whole slew of medications, and primarily those medicines are things like corticosteroids or prednisone for long periods of time, like over 3 months consistently, but even, repeated steroid injections into the joints can be causing, more bone to be broken down. And then other things like aromatase inhibitors for use for breast cancer. So this is a very popular and common use for estrogen receptor positive breast cancer patients, which is again important for preventing metastases and survival, but this severely impacts the bone as well.
What are the most common symptoms? So you've sort of laid this out. We have a bunch of causes, and I have to say that's really helpful because, again, we're looking for the red flags and we're doing everything that we can to diagnose earlier. So what are the most common symptoms, signs that you'll see in your office?
So this is what makes osteoporosis and bone health challenging, but in my mind, I think also just exciting and fun, is that there's osteoporosis is silent. So, it is silent. There are no symptoms of osteoporosis. So often I have a patient who comes in and says, aha, I have a T-score of minus 2.5. I have osteoporosis in my left hip. I knew it. It's been bothering me for years. And I say, oh, I'm so sorry. That's actually probably another musculoskeletal condition, maybe arthritis, maybe bursitis, maybe piriformis syndrome, because osteoporosis, you're not going to feel that unless you have a fracture. But the flip side of that is actually vertebral fractures. And we have 33 different vertebrae in our body, from our cervical, thoracic, lumbar, and then sacrum and coccyx, which are fused. And those can break. And occasionally we see those fractures that are asymptomatic or just found on x-rays, or someone has back pain and it's sort of brushed aside. Do some PT, we'll see you back. And then eventually they get an X-ray and MRI and it shows that they've had a fracture. So unless there's pain or some, event like a fall or a fracture, we really don't have a lot of symptoms of osteoporosis. So this is what makes, I think, identifying women with osteoporosis and osteopenia a little bit of a challenge. So we have to kind of look at those risk factors we talked about to understand, am I at risk? Should I get a screening test? Or is my back pain or my height loss, which is another big one, if women have lost more than 1.5 inches of height since their adult peak. And I always say no cheating with like no hair height, gains, or, no wishing what your height was. And that's actually important. And that's why when you go to the doctor, you should be measured, not on one of those clunky, sort of thing that you were measured on when you were younger, but actually a wall mounted stadiometer that actually accurately reflects your height from year to year. Because again, this can be a silent condition, and we can, and I see weekly women with vertebral fractures due to height loss and just being found incidentally.
Now, you mentioned T-scores, and so I'd like to move us. That you've done a great job of helping us understand some of the causes. It's fascinating that this is a silent disease, and anytime there's a silent disease, it's difficult, and so you really have to pay attention to anything that may put you at higher risk. You mentioned a T-score. What's that?
Okay, there's actually two ways we can make a diagnosis of osteoporosis. The first is actually just having a fracture. So we call that a low trauma fracture. We're moving away from the term fragility because who wants to be fragile? And that doesn't really explain anything. So a low trauma fracture, which is a fracture of a standing height or less. So that's a fracture of, again, of a significant, like a wrist, a forearm, the pelvis, sacrum, which is the bottom part, a vertebrae, hip, ankle. Some of the other fractures like a clavicle fracture or a rib fracture, sometimes we kind of have to hear about the history of those, but generally any major osteoporosis related fracture from a fall from a standing height or less actually is equivalent to a diagnosis of what we call clinical osteoporosis, and it requires, again, that next step of evaluation, treatment option discussion. And I think that's one that is still in the medical community is one that is kind of underappreciated. And I think even amongst patients I see, sometimes they want to fight me on the fact that anyone would have fallen or fractured if they had stepped off the ladder off, or they hit the curb in Chicago here on the ice and they broke their wrist. But I say, either way, this is a herald sign. This is a sign that we should be doing, something to look at deeper into your bone health. And then the second way to make the diagnosis of either osteopenia, osteoporosis, or maybe it's your lucky day and you have normal bone mineral density, is to do a DEXA scan. And what that stands for is it's short for DXA, which is a dual energy X-ray absorptiometry. So a fancy, basically way of saying that we're doing an X-ray on a machine, which is called the DEXA machine, of looking at your bone mineral density. And that gives us sort of a snapshot of what your bone strength is. And actually the bone mineral density estimates about 60% of your bone strength. So not the whole way, but a pretty good estimate. And what we do is we're scanning areas like your hip and your femoral neck of your hip, which is the inside part of your hip, as well as your spine and the vertebral area of your spine, and sometimes a forearm if we can't estimate those other sites. And it looks at the standard deviation of your bone mineral density from someone who's hit a peak bone mass. So we talked about, again, how we deviate from that peak bone mass as we age. And so a T-score is that fancy number, that standard deviation that you get of looking at your bone density and compared to someone who's of a peak bone mass. And this has been, again, validated, many times over in the scientific literature from the World Health Organization, adapting these recommendations. And the reason we come to a T-score of minus 2.5, which is the sort of the number that we look at to diagnose osteoporosis, or one way, is that we see that at least a third of women or more with a T-score of that low bone mineral density reflection will sustain an osteoporosis-related fracture. So it doesn't mean that everyone above and below that should just be ignored. It just means that this is one of the areas that we sort of see a change that we need to make in action. And we can actually, again, make a difference in treatment effect. Sort of similar to like the cutoffs for LDL cholesterol or hypertension is how I just sort of describe it.
Actually, I want to go deeper into the DEXA scan.
Yeah.
Certainly, I hear a lot about it as it pertains to bone health, but not only bone health, also muscle health, because you can get a lot of information about, percentage body fat, percentage muscle, and then the strength of the bone. So DEXA scans are really helpful, especially in a disease where you don't get a lot of signs and symptoms. However, I have to ask the question, when should people get a DEXA scan? Because I'm not aware that it's standardly done as your like annual wellness. This is not something I believe that happens early. So take me through that.
When we think about bone health, prevention is important. And you're right. Often in this country, the recommendation for a first-time screening DEXA across the board for women is 65 years. And for men, it's 70 years. And so, this discussion, if you've been listening intently, we've talked a lot about, the premenopausal years and menopause. And 65 is generally quite at least 15 years and sometimes even more past the time of menopause. And so, these recommendations are generally, again, appreciated by all the medical society guidelines across the board, and also generally dictated by Medicare coverage. But we know even when we look at, across the board women who are getting a DEXA at 65, we're still not doing a very good job. Medicare information shares that there's about less than 30% of women who are getting appropriate screening DEXAs even at age 65. Wow. And probably why we have a very serious issue with women having sustaining osteoporosis related fractures. And I'm in the camp of internal medicine and gynecology, so I follow the Menopause Society guidelines, the American College of Obstetrician and Gynecology, the Bone Health and Osteoporosis Foundation. These are all sort of the key players in midlife women's health. Really, again, recommended DEXA scanning at the time of menopause if you have risk factors for osteoporosis. So we talked about all those risk factors. I think there's a large bag there that many women fall into, having a couple of those risk factors. It's one of the reasons why I have invested in a DEXA scanner in my office. I think it's just so valuable to have that information and give patients that information, even in the perimenopause and menopause transition. So I do a baseline DEXA on all patients and on all women. And then I also, you mentioned the body composition DEXA, which is, I think, why we see more of this in the commercial space with various companies cropping up to give just patients information, right? We're a data-driven society now. And so DEXA can also be used to check for lean body mass, fat mass, visceral adipose tissue. So I also, use that as well. The main caveat I would just say with doing a DEXA for body composition, and then when they share the total body bone mineral density, that's actually not validated information. So the way we diagnose osteoporosis isn't by looking at every single bone in your body, including your ribs and your fingers, and then, spitting out a total body bone mineral density. We use that in pediatrics, but we really don't use that for adults. So we really need to be looking at those site-specific areas like our femoral neck, our hip, our spine, and our radius to really diagnose osteopenia, osteoporosis, and get an accurate reflection of bone strength.
That's helpful because I think, so what you're essentially saying is DEXA scans are not all created equally. It depends what the indication is. If you're younger, you're 30 years old, you have no risk factors, and you're doing it merely because you want to get a sense for muscle, fat, bone, fine. But if you're actually trying to make the diagnosis, again, correct me here if I got this wrong, you need to do a very specific DEXA scan. But I have to say something, 65 years old strikes me as somewhat late. I mean, you just made a very good case that, especially for women who have menopause earlier than would be usual, those people are at higher risk. And then there are all sorts of other people who are at risk. So it strikes me as like, hey, Are there other indications for people to get a DEXA scan? Because I want everyone to be mindful of this. If the indication is at 65 years old and you don't have other reasons to get it, then you're likely going to be paying out of pocket. Insurance will likely not cover this. But what about women who are at risk? Can they get an earlier scan and have it covered?
These are the hoops we jump through in the medical community to do that. And we do have the indications. As I mentioned, the medical society guidelines do say, women who are 50 to 65 or whenever that menopause transition with risk factors. And so I think a little bit of this is about coding for bone mineral density. So women who've had height loss and we need to check that they've had fractures, that is an indication. If you have family history of osteoporosis, if you have any one of those conditions that I mentioned, inflammatory conditions, cancer conditions, et cetera. Those are all, indicators that this is an indication. We call that an ICD-10 code in our medical speak that, for bone mineral density screening. And it's interesting that you mentioned this. Oftentimes what I see is I see patients coming to me saying, I told my doctor that I needed a DEXA. My mom had osteoporosis. And they thought you're fine. You have normal menopause, your age and, weight are appropriate. And then lo and behold, a couple years later, they get a DEXA and they have osteopenia or osteoporosis, and they're coming to me frustrated that the diagnosis was made too late. And when we look at 1 in 2 women over the age of 50 have fractures, we can prevent a lot of fractures with prevention techniques like earlier screening. I think the biggest issue is that when we do wide scale research like the United States Preventative Services Task Force, and they're looking at, groups of individuals and global, they're not looking at individual patients, the indication for DEXA is always sometimes on the chopping block. Like, well, does it prevent a fracture at 80? Well, we certainly have good information, right? If we get a DEXA earlier, potentially, again, we'll talk about treatment here in a little bit. Would we change our lifestyle? Would we improve our calcium? Would we work on our resistance training? Would we consider hormone therapy, right? So there's a lot of things that we can do. And so I think that that's the case for doing earlier DEXA, which again is a DEXA scan is low risk, low radiation, pretty inexpensive test. It takes about 10 minutes. I think the biggest issue is now some of these are being done at the hospital. The cost can be a little bit higher. So that's why I think we're seeing them more in these freestanding clinics.
Kristy, how expensive are DEXA scans? Because I'm sitting here thinking, hey, I don't want to wait until I'm 65 years old to get this scan. I may decide to do it earlier. How much do they cost? How can you shop for them to get a reasonable price? And then who are the people that should be thinking about this, and when should they do it?
So cost is always a hard one to nail down. So generally in some freestanding clinics, the DEXA scan can cost about $300, out of pocket to up to $1,000 or more, at a academic institution such as where I worked. So I think that this is obviously a wide range, and I think the indication matters. And then when we think about who should do this, stop, and particularly when we think about women, it really should be at the time of, menopause or the menopause transition. And that is generally, again, taken from science. As we know, even the menopause transition, which we call that sort of the years before and after menopause, we know that it's not just overnight that the bone is, you now have gone from normal to osteopenia or have osteoporosis, but we know that decline in estrogen, that increase of something we call FSH, really, again, translates into the bone dropping. And then the amount of bone loss decreases after the menopause transition. So I would generally recommend a baseline bone mineral density at the time of menopause.
Yeah, I think that's really helpful. And you touched on the shopping component, because that's something we commonly see in medicine, which is, with one practitioner, you might get a charge of about $300, but you can go to a big, academic clinical hospital and it'll be 3-4 times that number. So it is definitely worth a call in advance to find out what that number is. And also I think it's really helpful to know that around menopause, you want to get that baseline. I think that's a really helpful thing, because you mentioned this earlier, you're more likely to act on it. Let's say you have some signs that are consistent with osteoporosis, osteopenia, then you're more likely to focus on taking care of yourself so that you can prevent any problems down the road. Next, Kristy and I are going to talk about treatment, specifically what she thinks of hormonal replacement therapy. But first, a word from our sponsor. C2 Sense is doing important work with its Halo platform, applying technological advances in chemistry, machine vision, and material science to provide both patients and providers with laboratory-level accuracy at low cost when they need it. The pandemic reinforced the importance of being able to test in the privacy of your own home. C2 Sense's goal is to use their patented technology to ensure the same quality of testing you would find in your doctor's office in the comfort of your own home. So if you're suffering from upper respiratory symptoms like cough, sore throat, nasal congestion, or a headache, keep your eyes out for C2 Sense as they're developing tests targeting upper respiratory conditions such as COVID and flu. If you want to learn more, see what they're up to at haloreader.com. You've made the diagnosis, and now it's time to treat.
It's really important that we don't just jump to treatment. A diagnosis of osteoporosis isn't just due to postmenopausal women or ethnicity. There's a lot of other secondary causes that we look for. So such as like if you had cancer, we would do a CT scan. We would look for other reasons. Where is this located? The same for osteoporosis. So there's some basic, blood and urine tests that we do to evaluate for what we call secondary causes of osteoporosis. So checking for things like vitamin D, your serum calcium. We check something called a parathyroid hormone. We rule out other things like multiple myeloma. So we check a serum protein test. We can do other testing for celiac disease. So sometimes some things in the clinical history or lab work sort of tip us off to check for these things. And sometimes we need to add a couple things on. One that's generally not done often is one called the 24-hour urine calcium collection. And that really looks for how much calcium is either being excreted or how much calcium is being taken in. And then once we've done that, is we look at the fracture risk. So if you were my patient coming in today, I would say, okay, well, let's match your T-score or your fracture history with the treatment that we should provide. And what we really know from our literature is that if you've had a fracture, a major osteoporosis related fracture, as I mentioned, if you have a low T-score, we're talking now like T-score of minus 3.0 or lower, or you're, in their mid 60s or beyond, those women are really at the highest risk for recurrent fractures or a primary fracture. And so we treat those women more aggressively or more proactively, and generally try and reach for medicines that are osteoanabolic. So remember, pulling back in our term of those medicines that stimulate more of the osteoblast rather than the osteoclast to really fill in the new bone. We know this from multiple clinical studies. We know this from looking at bone biopsies, a very painful procedure that we don't do routinely, but we do in clinical studies to look at how the bone cycle and the bone modeling and the bone physiology is doing on these medicines. And so we really try and counsel on those medicines. We have a couple in our armamentarium. Generally, they are daily injections or monthly injections given by healthcare providers. And so take quite a bit of counseling. There's risk benefit that we talk about, but the reason we choose a lot of these medicines is they really have the biggest bang for our buck when we use them initially. They improve the bone mineral density over 10% many times, even after a year to 2 years, which is actually equates to a whole standard deviation on a T-score. So we really can move the needle on strengthening the bone. And then we think about, again, looking at other medicines after that.
So that's really helpful. So those are the most severe patients, right? And for those people, they're going to need pretty intensive treatment. When you talk about injections, what about other people, maybe that don't have quite as severe a T-score, haven't had problems with broken bones, but are at risk if they don't intervene? How do you treat those folks?
We have a lot of some great medical guidelines to help us, the Endocrine Society guidelines, the Bone Health and Osteoporosis Foundation. And this is where, I as practicing this field for a while, look at really women across different decades of life, like, right, matching their fracture risk, matching other, patient preferences, obviously cost, all of these things. And when we think about the large majority of medications that are in the class of anti-resorptives, we call that, or preventing the osteoclast, those are things like Fosamax or alendronate that's been FDA approved since the 1990s. Those are estrogen or hormone therapy that's been FDA approved since the 1940s and was actually the first medicine to be shown to, reduce vertebral fractures and prevent calcium losses in the bone in postmenopausal women. So we really have a lot of good options there. We have some yearly injectables, which is called zoledronic acid. We have one that's a monoclonal antibody called denosumab. So again, there's a lot of options to discuss.
I want to ask you about hormone replacement therapy simply because menopause is getting its day right now, and this is a long time coming, and I'm really excited that people are paying attention to this. People like you have been after this for over 15, 20 years in trying to promote women's health, and now we have a great conversation within the medical community about its importance. Hormone replacement therapy is one of those things I think that's confusing the most. And so I'd like to talk about it in bigger terms, not just in terms of bone health, but the whole concept of hormonal replacement therapy. My understanding is that there were studies, one study in particular that was done back in the early 2000s, if I recall, and largely that was the outcomes of that study. Those data were misinterpreted, and subsequently HRT got a bad rap for many years. So what's your take on HRT? Tell us a little bit more about that study and what happened there, and then where are we going with HRT?
Yeah. So this is a long-winded discussion, but really I think so important because again, if we understand the history, we can move forward correctly. Hormones have been, FDA approved since the 1940s. We've had birth control pills, thankfully, for so many years for reproductive age women. And then we had a lot of research in the early 2000s, the 1980s, 90s, showing that hormone therapy was very effective at, again, controlling hot flashes, potentially effective in controlling, chronic disease management or preventing chronic diseases like cardiovascular disease, like dementia. And so this large study, the WHI, which I think is probably the most discussed study in women's health, was undertaken. And again, this was actually a prevention study, a study looking at hormone therapy and could it prevent disease. And so, this was a large, again, NIH study that was 27,000 postmenopausal women. Keys to the study were that these women were on average 63. So we've been talking a lot about the menopause transition and sharing that that's generally between 45 and 55 for a majority of women. But the women in this study did not have hot flashes, didn't have menopausal symptoms, and were beyond the menopause transition. And were given estrogen alone, which was Premarin or conjugated equine estrogen orally. And that again, if they did not have a uterus, or women who had a uterus were given combined estrogen, progesterone, conjugated equine estrogen plus Provera or medroxyprogesterone acetate, which was really the hormone therapy that was du jour during that time. We didn't have as many of the different options for bioidenticals or different delivery systems, doses, et cetera back then. But again, the study was done and undertaken. And it showed a lot of positive, and then unfortunately, some of the negative were kind of overinflated. What it showed in women who are on average, again, in their 60s, but women were studied from 50 to 90, it showed that it actually decreased the risk of osteoporosis-related fractures, improved bone mineral density, decreased the risk of things like colon cancer, cardiovascular disease, insulin resistance. And in women, again, when we looked at stratification by age, so women closer to the menopause transition, the benefits were really outweighed the risks. The concern was that in women who are on estrogen plus progesterone after 5 years, there started to be a difference in the rate of breast cancer. And that is where the overinflation sort of happened with the media, is the difference in the absolute risk for breast cancer was one additional breast cancer per 1,000 women per year. But when we looked at that on the flip side, the relative risk compared to women on hormones versus placebo was increased over 30%. And so that's really what got taken, what got run with, and hormone therapy, really the trajectory of prescribing and understanding really changed. However, when we really bring it back to, again, focusing on osteoporosis and bone health, and then all of these other, constellation of symptoms and other medical concerns and issues, we know that hormone therapy has been in standard of care for improving bone mineral density and decreasing both hip and vertebral fractures and non-vertebral fractures. So the FDA indication for hormone therapy is actually to prevent osteoporosis. And so this is maybe a little known fact because most women at the time of menopause are going on hormone therapy for things like vasomotor symptoms, hot flashes, night sweats, vaginal dryness, mood symptoms, joint complaints, inability to sleep, all, again, many different symptoms, maybe over 100 menopausal symptoms. But bone health is generally neglected and forgotten. So the WHI kind of did a disservice, or at least the aftermath of the WHI has done a disservice on women who are prescribed hormone therapy, but it's really important to understand the nuances and then again prescribe it for women who don't have a contraindication, of which there's a couple: women who've had a heart attack or stroke, women who've had a unprovoked blood clot, or women who have undiagnosed genital or uterine bleeding that we need to take a look before we prescribe any hormones, which is generally a recommendation for all of our hormones that we prescribe, even contraceptives. And I think because of the WHI, we've lost about 20 to 25 years of medical education, providers, clinicians, understanding, and then that trickles down to, again, all of our patients and what we recommend and offer to them, with the awareness that, we have estrogen. And when we lose estrogen, for some women, that is a really significant issue. And we know that when we look at chronic disease management, and I think this is the eye to the future, is we're thinking about will estrogen at the appropriate doses, formulations, et cetera, duration of time, help reverse some of these medical conditions like cardiovascular disease. Certainly, we know it affects osteoporosis risk and decreases the risk of fractures. And then looking to these other conditions as well to see what will happen.
Yeah, that's a very comprehensive answer, and thank you for that. It was confusing to much of the medical community because there were so many things that came out of that study. Again, I think it was back. Do you recall the year? Was it 2000?
Oh, 2. Yeah, 2002.
That were very positive and that were very good for women. And yet this one thing, which was really to a certain extent misinterpreted, or said better, miscommunicated in terms of what the risk was. You said the risk was actually 1 in 1,000 of developing breast cancer, and most people would consider that, and we're always balancing risk benefit. That benefit would far outweigh the risk, and somehow that got sideways. And to your point, we lost like 25 years of good treatment. That's changed. And we're back. And so clearly you are a fan of hormonal replacement therapy where it's appropriate, where you don't have a contraindication in women, because it's going to decrease osteoporosis, osteopenia, and people are going to do better. Now, you took us through a bunch of things, like very intense treatments in terms, even those that require injection, other medications that clearly need to be managed by a provider, and now the importance of hormonal replacement therapy. What about the basics? How do you think about diet, exercise, resistance training?
So this is, again, the building blocks for bone. And I always describe that. And that's why we're checking for things like vitamin D deficiency, talking about, calcium-rich foods, which doesn't always need to be milk. There's a lot of non-dairy sources of calcium out there, because we know that when we do our placebo-controlled studies, when women are on calcium and vitamin D, those medicines work better. Even hormone therapy worked better when women had adequate amounts of calcium and vitamin D. And that varies, again, based on how much can be taken, your age, how much can be absorbed. Generally, for postmenopausal women, we're looking at 1,200 milligrams of calcium in diet and or supplements. There's such a wide variety of different types of calcium supplements.
But I will say that you are a fan of calcium supplements. I know that's a question of itself that people want to know. Do they work? I've heard from some that they don't. It's a waste of time and money. And others say, yes, calcium supplements work. What's your take?
Yeah, I think, again, it's the verb supplement is to add, right? So when we think about calcium, our bones are made of calcium, phosphorus, a bunch of bone cells into a matrix. And so, again, I always go back to the science, as we know that when we actually study the pharmacology, we study the medications that we use, when women are taking calcium and vitamin D, they work better. So we know, based on these studies, that they are doing something to help us mineralize our bone. And as I shared, when we remodel our bone, if we don't have the building blocks there, it's kind of like pulling sand through your hands, and that's just going to dissipate. So it's important to get these. Now, sometimes I see women who are overshooting and, if they think, 1,200 is good, they need 2,000 or more. And that can contribute to things like constipation and kidney stones. And that's, again, where the appropriate calcium exists. But I think this is an important molecule. I mean, calcium is everywhere in our body, right? It's not just in our bones, it's in our heart, it's in our musculature. So, calcium processes are very important.
What are the foods that you recommend people focus on?
The International Osteoporosis Foundation has a great calcium calculator. So does the Bone Health and Osteoporosis Foundation. So I generally ask, women, what calcium-rich foods are you taking in every day? And then start from there rather than telling them what I think they should do, right? Because everyone comes from, different backgrounds. And so, things again like milk or milk alternatives have, calcium. Many of them are fortified now, like almond milk, oat milk, soy milk. These are all fortified or just general old cow's milk at different varieties. Cheese, yogurt, and even some of these plant-based, options now are heavily fortified with calcium. Leafy greens have some calcium. Salmon with bones have some calcium, nuts have some calcium. So sometimes it's adding some of those things together. And then if we think a supplement is important, then also adding that at the right amount without, going over. It's kind of like the Goldilocks phenomenon. And then vitamin D also helps absorb calcium. Vitamin D receptors are everywhere. I think during the COVID pandemic, people are overshooting on the vitamin D a little bit, but we know there's vitamin D receptors on immune cells and other cells. So vitamin D is also important. So making sure patients are getting adequate level doses and then checking those levels in a blood work as well. Important. And then other things that we just talk about for good health. So getting adequate amounts of protein. That's probably more helpful for muscle mass. But again, we know muscle supports the bone. That's important for just the larger picture of aging. For instance, when I see my women in their 70s and 80s, making sure they're getting enough protein so that they're not developing muscle loss, something we call sarcopenia, which also would increase their risk for falls, right? So it's not just one piece to the puzzle. It's really, again, looking at the lifestyle, nutrition, and then you mentioned exercise. I get this question all the time, like, what's the best exercise for my bones? And I always say it's kind of like going into a restaurant and saying, like, what's the best food you have? I mean, they sell food there. So, they're going to offer you something. So I think that, and research in exercise is just so challenging to do. Us scientists like to have nice placebo-controlled studies where we have one group doing something and the other group doing the other. But when you do exercise, these studies, it's hard. People are moving around. They're doing different things. And those studies generally then are going to be smaller in time. They're going to be 1 month to maybe up to 3 months. And they're having people do either jumping or running or lifting weights. And all of those things are positive. And the large meta-analyses or studies that we combine together really, again, show, getting off the couch is better than sitting on the couch. And so I always say, starting from where you're at. So incorporating aerobic exercise, whether that be, again, walking, running, dancing, racket sports, doing some sort of posture balance coordination. All my patients know that they are going to practice their balance with me for 30 seconds every time they come to see me. So we practice balance, making sure that you can do that, functional movements, avoiding any like falls or sways if I kind of tip you to the side. All of that is so important because that changes as we age, right? And then the resistance exercise, which I think is a huge conversation now in social media and in general, because we're thinking about muscle, we're thinking about bone, we're thinking about longevity. And so anything you can do to maintain muscle mass, because again, that starts to decrease when we start to decrease our testosterone and other sex hormones, even start at the age of 40. And we know that with every decade of life, we lose about 10% also of our muscle mass, more closer to our 60s and 70s than earlier. But that again impacts fall risk, balance, etc. So doing compound movements, different resistance with weights, bands, your own body weight, using exercise professionals to help you. But again, doing that routinely, right? We don't want to be just the one weekend warrior, but doing that a couple times a week can be helpful. And I understand it's a high charge, for a lot of my patients who are busy, professionals running their families, doing other things, but trying to fit those things in a smart way, I think can all work together nicely.
That point is really well taken, which is the moment you start talking about resistance training is the moment people conjure up this idea that you're in the gym and you're pumping iron and that's the only type of resistance training. Untrue. You said this nicely. Band training. It can be core body weight training. It can be weights as well, but it doesn't need to be in the gym. You can have dumbbells at home, really simple. The truth is, buying some dumbbells at home and incorporating some body weight exercises will be enough for most people to actually get the exercise they need. And so that's really helpful to understand that resistance is key. You want to make sure that you're building muscle as you're aging. Balance is key. I work out with a group of guys 3 times a week. And earlier this week, one of the guys recommended, are you familiar with an electric toothbrush? And like after 30 seconds, it either for some brands beeps, or for others like mine, it pauses. And what he said he started doing is standing on one leg while he, brushes his teeth for 30 seconds. And it's funny, that's exactly the amount of time that you recommended. And then when it beeps or, pauses, then he switches. And what he's doing here is really fascinating, which is he's taking an embedded habit, which is brushing his teeth, and he's kind of adding on another, which is balance training. And I think that's brilliant. And if you can do that, it's a really, really great approach. Okay.
And then now you need to tell him he has to do it with his eyes closed.
Yeah, that's the next piece. We didn't talk about that. That feels like it could turn into some unwanted fractures potentially. All right.
Yeah, get back to me on that one. Okay.
All right. So we've been through all of this. We talked about treatment in terms of medication. We talked about it in terms of your diet, supplements, and now the importance of resistance training, exercise just in general, and balance. What are we missing here before we wrap? Anything else that we need to get into before we move on?
I think again, the combination, and this is why I say bone health isn't just about, medications, because I think a lot of women come to see me very fearful about the side effects that they've read, or just about starting medication for osteoporosis where they have no symptoms right now. So why would they sign up to get a potential side effect that they're reading, on a glossy label here? So I think, again, it's not just about the medicine. It's about lifestyle. It's about calcium, vitamin D. It's about exercise, and it's about understanding your risk for fracture. What are we trying to understand from doing a DEXA to evaluating for osteoporosis and treating, right? What are the goals of care? And I think, again, that varies based on the decades of life. And maybe I think I see that a little differently just because I treat women through, the lifespan. But I think, again, it's different in women who are in their 40s or even starting in our 20s, 30s, 40s, all the way up into women who are in their 70s and 80s, or even someone who's sustained a fracture already. What are the next goals of care?
You have been exceptionally generous with your time. I want to thank you. But before I let you escape, I'm going to take you into sharing beauty, which I talked to you about before we started the episode. It's something that my family and I have been doing for a while, and I know that you have something in mind. So what beauty do you intend to share today?
Well, it is summertime in Chicago, and I am a country music fan, love it or hate it. And I really like Kenny Chesney's song, Get Along. I think it's just a nice reminder that if there's anything we can do in the world is to be kind first, get along. And there's also a reference to calling your mom. So let's be kind, get along, and call your mom.
I like that. Like, if you get nothing else out of this, call your mom, folks. It's a really good thing. Kristy, thank you so much. I've enjoyed the conversation. You really took us through a lot of information. I'm looking forward to having you back. I think that this is just sort of the tip of the iceberg, and I think we should go deeper. So thank you.
Thank you so much, Kevin. What a great topic. Happy that you're talking about women's health. We all appreciate it.
And thanks to all of you for watching. If you have any questions, any comments, if there are topics that you want me to cover, please leave them in the comments below, and I'll do my best to answer. That's our show for today. The show was produced by me and Batsheva Gez. Until next time, be well. This show's content represents my personal opinions. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not create a physician-patient relationship with me. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition or your general health.